So I've been charged today with talking about the non-surgical approach to the patient with hip pain. And when Karen initially gave me this topic, I thought, easy peasy, this is what I do every day. And then I sat down to write the talk, and I was a little bit like a deer in headlights. Like, okay, what am I going to tell this group, and how can I really relate to them what I do every day? So then, a very smart girl sitting next to me said, do cases. And I thought, you know what, that's brilliant. So I'm going to start with some cases. I'm going to start with a simple, not simple, but a bread and butter, a case that we see every day, and then we move forward with some of the more complex patients that we see. So this is a case of a 13-year-old dancer, and you're going to hear a lot about dancers today, and you'll hear more from Dr. Quinn later. 13-year-old dancer with unilateral right anterior hip pain. The popping's been present for a prolonged period of time, so 18 months or so, but really was never painful up until about 3 weeks or so. So we see this fairly often in our clinic. They present with hip pain. It's often insidious in onset, so it's not provoked by trauma, or it's not brought on by a traumatic event. And they have no other really symptoms. It's, they say it's in the front. They report this mechanical symptom. There's no instability, no neurologic symptoms. And we always do a quick, screen with regard to female athlete triad stuff. Do they have a history of stress fractures, et cetera, et cetera? Any constitutional symptoms? So your bread and butter, kind of intake questions that we do, and I have my go-to questions that I ask with most patients. So this is a patient with coxa saltans interna, or snapping hip. So we see snapping hip or popping hip all the time in patients, especially in the sports medicine clinic. And it's a major cause of anterior hip pain, especially in dancers, and we tend to see a lot of dancers. They can have a lot of popping in the hip. A lot of people's joints make noises. We get this all the time. What's important to pay attention to, what's not, what's clinically significant. We tell our young population, especially our dancers, to pay attention to the popping. It's often brought on by repetitive hip flexion, right? So hip flexion and abduction. So these dancers are doing this hours and hours on end. It's reproduced by a painful snap, right, by extending the hip. So we can reproduce this in the clinic. I think our clinical examination is critical in these patients, and I'll talk a lot about this as I move forward. We often, I'm ER trained. I often get criticized for ordering a lot of diagnostic tests from my ER colleagues, and the truth is that we spend a lot of time examining our patients, and that directs our management very, very often. And in these patients, you take the hip, you bring it into this, it's in this abducted flex position, and you take them into active extension, and you have your hand over the psoas, and they can often reproduce that popping for you. And that's pretty significant clinically. It's very common in student dancers, and I think that this study by Leibel, which was really just put out in the Orthopedics of Journal of Sports Medicine, it's more common in student dancers, and it gets less common as you advance in your career, so versus amateur dancers or at the professional level. And I think that this is multifactorial for different reasons, and the growth process being one of them, which I'll talk about. Technique, so these young dancers are just learning technique, and they're taught that they have to have this perfect turnout, right? This 180 degrees of turnout early on in their careers, so they tend to force it early on. So it's technique, they're trying to perfect that technique, and then of course, as they're actively growing, we see an increase in their dance training hours. So those two things happen together, and that's the perfect storm for injury. So the snapping hip, the internal snapping hip, so where does that occur? So people talk a lot about it occurring at the iliopectineal eminence, right? Or over that femoral head, so that's the two common places that people talk about that iliopsoas snapping or popping, so that's the mechanical aspect of this. And so we looked at this in dancers. So we had a large database of, and this is from our patients seen in our clinic over a 10-year time period. We isolated out the injuries in the dancers. It was a random sample. And what we found, and I know these percentages are really hard to see, but if you just look at the two dancers and you look at the dancers that are less than 12 versus the ones that are older than 12, the injuries go up. They go up to the hip and up to the spine as growth occurs. So after growth, we start to see more injuries at the level of the hip and spine versus in the younger prepubescent dancer, the injuries are really lower down towards the knee and the foot and ankle. So we see a difference in the injury incidence as these dancers go through growth and puberty. So this was a study that actually will be presented at FIMS next month, and this is, so we looked at, again, this is the same database, but we looked at hip injuries. So we looked at we took a random sample of all injuries over a 10-year time period seen in our clinic, and we really wanted to assess the pattern of hip injuries in young children, and it was a retrospective chart review, it was a random probability sample, and we looked at the differences in diagnoses of the hip in females versus males, and our age range was 5 to 17 years, and you can see that these diagnoses differ, right? So the female, we see a high percentage, so 59% of labral tears. We saw tendinitis and snapping hip, and I know those two go together and overlap. Strain, and then bursitis, so more soft tissue type injuries with labral tears leading the list. And then when you look at the males, again, labral tears are high on the list, but we see more bony type injuries. So avulsion fracture was high, slipped capital femoral epiphysis, which you've heard about, dislocation and tendinitis. So different profile of injuries based on the genders. And this was a 5 to 17-year-old group, and this will be presented next month at FIMS. And then here's what we found when we looked at a gender comparison by age. So if you look at the younger age group, a higher proportion of the males actually have hip injuries, and then as you go older to the older age group, 91.8% of the proportion of injuries is in the females. So a much higher proportion as females are post-pubertal, if you will. And we had to draw a line in the sand somewhere, so we drew it at 12 years or older. And then we looked at injury type, and by far and away in the females, 95% overuse in nature, and we characterized those. And then the bony versus soft tissue, and again, a large proportion are soft tissue injuries in the females. So what about the medical management? So this is what I want to focus on today. And we talk about, so we have these very active young kids in clinic, and what do? So we have to get their pain under control, and that's what I feel when I see them, that's first and foremost is a priority. They can't move along. You guys, I know a lot of this audience are physical therapists, and it's hard for the physical therapist to do their job unless I do my job from the get-go, right? So we oftentimes in sports medicine in particular will not take them out of all physical activity, but we talk a lot about activity-specific rest. So it's rare that I say you cannot do anything, very rare. But I talk about what they can do safely and painlessly with the injury that I'm presented with. So pain management, I think that this is, pain's all over the map in these kids. Some kids are like, their legs falling off and they're like, I'm fine. I can just, and other kids, they have a little nothing and they're excruciating. So it's really, really hard. But I do often start with a very benign, short course of an anti-inflammatory medication. We rely a lot on, I don't want to get in trouble here, but we do rely a lot on the placebo effect. I think giving them a pill, giving them a prescription is really important, and it helps a lot. So we treat them, we treat their inflammation, we treat their pain. We can treat them topically safely if they like that. We use Voltaren gel sometimes. And different things are very effective for different people. We talk about ice and the fact that that's underutilized. It's a very safe, good way to control pain. So we do treat their pain very aggressively and very effectively, hopefully. We talk a lot about progressive early rehabilitation, and we rely a lot on our physical therapy colleagues, a lot. And I think it's a mainstay of what we do with these patients who are often very complex. And we especially a physical therapist who's well-versed in treating a young, actively growing athlete or dancer and well-versed in the hip and the injury that they're faced with. So I think that's critical to us. This is my kind of Strac thing, and I talk about exercise prescription. So I talk a lot about how if you have chronic pain, these kids are often very active. You take them out of their activity. They're not sleeping. They're stressed. Their world is somewhat rocked. So I talk a lot about safe exercise and how they can do cross-training, put them in the pool if you need to, so I think there's a big role for that. And then a safe return to sport or return to activity. And again, I use the physical therapist a lot to help me out with that. They're seeing the patient every week or twice a week, and they can really bridge that between the medical evaluation and the physical therapy evaluation and help return that child to sport. So in terms of the therapeutic interventions, I know I'm preaching a little bit to the choir here, but stretching, stretching is a very important part of treating these kids. It seems to be the most consistent intervention. When to do it and how much to do it, I think I'll defer a lot of that decision making to you guys, but I think it's important that I reinforce that on my side. I think kids can overstretch. I think they can add sometimes, create more micro-trauma if they're overstretching an acutely injured psoas, but nonetheless, I think it's an important part of the treatment. We talk a lot about eccentric strengthening of the hip flexors combined with a concentric strengthening of the hip internal and external rotators, and I think there's some good data to say that that's can be a very successful protocol. Iontophoresis, so you guys know this a lot, but so topical ways to treat their inflammation and move them along. Again, ice and heat, or specifically ice, I think is underused and I think needs to be emphasized. And I think when the patients hear us talk about it from the medical side, they tend to, really, or from the medical side, tend to use it more if we reinforce the importance of that. I think there is a role for deep massage and myofascial release. And I think that when you bring these things up to patients, it never occurs to them to even think about looking at these ways of treating their pain, but I think it can be very effective. We talk about neuromuscular re-education and what to turn on and what to turn off. And by all means, I'm not a biomechanist, but I think it's important to at least bring this up to the patients and talk about how, try to learn how and have people out there, the therapists, exercise scientists, or teach you how to use your gluteal muscles. They may be strengthening them every day, but how do you use those? And how do you turn off that iliopsoas? And I can't speak to this, in a deep way because it's not what I do every day, but I think it's important to at least bring that up and how this plays into treatment of their injury. And Carol Lewis, actually, there's an awesome article written by her. She's going to be talking later, and I took this out of her article, but I would highly recommend reading that. So what about, does conservative or non-operative treatment of iliopsoas tendinitis, and I wouldn't say non-operative, I would say less invasive, so does it work if you just treat them with some pain management and rehab, and do they get better? And I think there is not so much data out there, but this one study popped up recently, and patients with clinical exam very supportive of iliopsoas tendinitis, so a positive iliopsoas test, and I'll show you a picture of that. And your typical clicking and popping. They actually did quite well, So, over the course of this study actually didn't give a lot of detail in terms of how long they treated them, et cetera. But nonetheless, they had a good response with and this was in dancers with iliopsoas tendinitis. So there is some data to say that, just treatment with a good physical therapy regimen, a relative rest, et cetera, these dancers can do well if you catch them early and treat them effectively. And so this is the two clinical exam tests that they really pointed out in this study. So it's that weakness with that hip in the abducted, externally rotated position, and then looking at, psoas excursion or looking at the tightness of the iliopsoas. So when do we consider iliopsoas bursa injections? And I think that this is a very difficult question, and it's very dependent on your patient, on your dancer, on your athlete. And we struggle with this a lot. And I think we here at Children's see a very young population. And I think it needs to be well thought out, well-intentioned, clearly, which is, and it needs to be a decision that you make with the patient and the family. So when do you think about this? And where are they in their careers, if you will? Are they in season, out of season? Have they plateaued? And we really use this to help these patients get over a plateau or get over a hump. So really, every patient is a little different, and you'll see it all over the map in terms of the literature, when to think about it. And I've seen even in some really good journals that they even think about it at 2 weeks, which I think is very early. But typically 6 to 8 weeks, if the patient's not getting better, they're really frustrated, I think you can start to think about an iliopsoas bursa injection. We use it for multiple reasons. So one clearly is to help the patient get better, make them feel better. We do the dynamic ultrasound evaluation when you're doing the injection is very helpful. As Dr. Demacourt showed you, you can look at that psoas, you can see the bursa underneath, you can look at the joint anatomy nicely, you can see dynamically if you have them move the hip with the ultrasound probe in place, see the movement of that iliopsoas tendon. So we use it dynamically, so the injection helps in that way. Or when we're doing the injection, you can get some good information, and we use it diagnostically, right? So it gives us information that way, and I think that is huge for us and huge for our hip team in terms of, if they're not getting better, we start to think, okay, what else is going on in this hip? When do we get advanced diagnostics? And if we do an injection and it really helps take away their pain, and we mix the steroid with a little bit of lidocaine, and immediately after on physical examination, they feel a lot better, I am much more reassured that that's an extra-articular source of their pain versus intra-articular. The restrictions after the injection, so we often will recommend, and this is really for multiple reasons, but one of the big reasons is if you want this thing to really work, this injection to work, you really want them to rest for a little while afterwards and not stress the hip. So, again, it's a little bit all over the map, but we tend to talk about 7 to 14 days and then a slow return as tolerated. There is a little bit of a risk of a corticosteroid flare. It's really due to the preparation of the medicine and the way the body reacts to the medicine, the crystals in the preparation. This happens pretty commonly, and it's hard to know whether or not the psoas is just inflamed and aggravated to begin with. Then we do a gazillion million physical examination maneuvers on it. Then we stick it with a needle to with lidocaine. And so we're manipulating it, and the patient walks out, and that next week, Mark Baldwin talks to me about it because he sees a lot of my patients. Like, the patients are like, my hip is killing me, and they're mad, right? They're like, they expected this injection to help right away and to give them a new, and then they're mad because it's killing them. And I warn them about this, but sometimes I think that we need to be better at really educating the patient, saying, your hip may be more inflamed for the first week, and this could be a reaction to the medicine, it could be a variety of things, it typically does get better. And you need to really set expectations and let them know that this is a possibility. And then there's always a risk of no response, right? So that's, again, it's all about setting expectations. And it doesn't work in everybody. And some people don't even respond to steroid, just like someone won't respond to Advil. So you really have to talk them through this before you do the procedure. What about, what medicines do we use when we do these injections? So the best preparation for steroid choice is really a steroid that's high potency, has a long duration, and a low solubility, right? So the ones that we tend to use are the betamethasone and the triamcinolones, and most of the studies talk about triamcinolone. These are the two that we use. And if you look, I hope this projects, but the triamcinolone, in terms of, we look at duration of action, so optimally when you're putting something in, you want it to stay where you put it, right? So you want a low solubility, but you want a long duration of action. And these two actually fit this criteria quite nicely. And this one, we tend to do our triamcinolone or Kenalog, tends to be the one that is more, it's the nicest in terms of putting it into the joint in terms of the cartilage environment there. So we tend to use Kenalog for the intra-articular, and then betamethasone for the soft tissue. But there's a lot of studies out there that use the Kenalog for even the soft tissue as well. What do we talk to the patients about when we're about to do these injections? So there's Facial flushing is common. It's usually somewhere in the range of 10 to 20%. It's more common in females. I've seen some reports that it's even up to 40%. Steroid flares, I just talked about, it's pretty common, and I also think that's complicated by the fact that we're irritating the psoas a little bit. So is it a flare? Is it a whatever? I think that the psoas goes into spasms sometimes. The infection risk is really low. Again, it's all over the map in the literature, but we talk about 1 in 10 to 20,000. It's a needle poke. It's not a cut. We're pouring alcohol on the hip basically because we're so paranoid about infection. But so everything's sterile. We put a cover on the ultrasound probe. So it's really a low-risk procedure in that regard. And then what about the hormonal effects? So serum cortisol is suppressed in the first 24 to 48 hours, but then it returns to normal very quickly. Hyperglycemia in diabetics is an issue, and I think if you have a diabetic patient, you have to warn them that their blood sugars are going to go up. They have to adjust their insulin. Menstrual irregularities are not so common, but it does happen. So the females, you tell them that they may or may not skip a period. It's very unusual, but just to warn them not to freak out. It normalizes. Superficial injections into the soft tissue, we worry about skin discoloration and fat necrosis, and this actually is probably one of the only permanent effects that if this does happen, it's really, for the most part, permanent. Most patients don't care so much. We're doing a knee or a foot or an ankle, or we don't do superficial in the hip as much, but transient numbness of the quadricep nerves, so you have to warn them they can't stand up right away. And we're careful about, educating the patient in that regard. They have to hold on to steps, no driving. We have a protocol that they can't drive, et cetera. So you have to just be careful with that. And then what about how do these patients do, right? So there's not a whole lot of data, but Dr. McKaylee and Ruth Solomon, who's here today, they early on in the late 70s, they looked at the outcomes of iliopsoas burst injections under fluoroscopy and had some really good results, 13 excellent, 2 good, 2 good, and 13 excellent to good, and then 2 fair, 2 poor. And then in the post-op patient where we see psoas tendinitis often, a study by Adler in 2005, 90% relief, and a low need for revision surgery. And then Black and Baker in 2006, and they looked at iliopsoas injections with Kenalog, and they actually had a good response. And the follow-up wasn't quite as long. It was really a 2 to 10 month range, but a good response there. So I think there is some data out there, and I think the response can be good. And then what about when do we start to talk to our patients about releasing the psoas? Like if it's not getting better, do we bring? I think this is a really difficult one, and I hesitated to even bring it up. But and quite honestly, most of the time it's not even on the table. But it does come up, and I think our patients are very educated, and they ask about it. And the truth is, I think that in certain cases, it may be necessary. It's rare. It's not that common to do that, and I often defer to my surgical colleague. I talk to Dr. McKaylee and Young Joe and Bang and all these guys about when and if and da-da-da. But we treat these patients as a team, right? But nonetheless, this study is a good one in that. It looked at outcomes of iliopsoas release, and I'm a little biased here, but so there were 60% without complications, and I think that the take home there in my mind a little bit is that 40% did have complications. So it's you have to think about it, and you have to think about it. So anyway, and then the point is that these are the outcomes for iliopsoas release in a study by Gruen, and I think that if it does come to that, the results can be really good, and the patients can feel better, and their snapping resolves, and their post-op pain is less. But they are left, some of them, with some weakness. And in our population, we see a very young, active population that needs a strong, effective psoas. So again, you have to just think about it. And then what about an algorithm? So this I pulled from a paper from Johnson. It's dated, but I think it works. We don't have, we didn't write our own algorithm. I think that's coming. But nonetheless, I think it gives me, or you guys some visual idea of how we approach these patients. So History and physical examination is of utmost importance. We spend a lot of time, our clinics run behind because we spend a lot of time. Bridget and I saw a runner yesterday in our exam. We were on a psoas road, and all of a sudden she had focal bony tenderness of her pubic ramus, and we were like, okay, off that road, onto the stress fracture road. So our physical examination is critical. We spend a lot of time. We do get x-rays up front. We're a specialty clinic. We don't want to miss those dysplastics, so we tend to get x-rays. And then we go down our path, right? We treat them with less invasive, and then see how they do. The decision to get advanced imaging, I think, is a really, really hard one, and I think that it's not a slam dunk, like, oh, let's just get an MRI if you're not better. It's really not, because our patients are very active. I think the chances of the chances of getting an MR and then maybe of finding a labral tear, you have to really decide what you're going to do with the information once you get it. And so it's a tricky decision. I think that we put a lot of thought into it, and before we move on to advanced diagnostics, et cetera. So the second case, I finally gotten to my second case. I don't know if I'm ever going to get to my third, but so this is a 28-year-old with DDH. So this is a history of dysplasia. This is a patient now that Dr. Millis is Dr. Millis's patient. I helped take care of him, Mark Baldwin. Mark, so sorry. So anyway, 11 months status post surgery. So she had a periacetabular osteotomy, so, to correct her coverage. She was under-covered, so dysplastic, and so we did a surgery to correct her coverage or give her more coverage of her hip. She had persistent right hip pain for 11 months, a constant deep ache, and it had gotten worse. And these patients, they struggle a lot when they have persistent hip pain. These are often young females. They're very active. They're trying to maintain a very active life. They're professionals. They're parents, etc. And this patient in particular had difficulty sleeping. She was discharged from physical therapy for who knows why, and she wasn't doing anything in terms of physical activity. So it was a tough problem. So nonetheless, these are her x-rays. So this is Dr. Millis's hardware here, and then she had the hardware removed. And she said to me, my pain is really, her pain was like right there, right? I said, do you know? So she had very focal pain when she pointed to it, but she said that occasionally it's in the front, this occasionally it's in the back, but it's constantly always on the side. And so this is where, again, our physical examination, and Pierre and I, if you ever worked with Dr. Demercourt, he is the master. Like, he takes an hour to examine the patient, but nonetheless, he does. Trust me, but it's all worth it. So, you examine the patient, you find out where they're tender, and you listen to where they tell you, because you get on a road when you're starting to look at these x-rays, like, okay, I'm going to do this, I'm going to do this. But listen to where they tell you it hurts, and then go for the money, basically. But for her, her pain was multifactorial. She was a little bit hypersensitive over the lateral surgical site. She had some definite weakness of her hip abductors and flexors. She was tight. So I think her pain generators, were multiple. And so what do? So I treated her with an anti-inflammatory. So I gave her a therapeutic dose. A lot of these patients are taking an Advil here, an Advil there. So they have poor pain control. So you treat them therapeutically. Oftentimes we'll give them either BID naproxen, it's a 12-hour drug, or we'll give them a 24-hour drug, so they take one a day, and they have a nice constant level. And then I use water therapy a lot. I think Pierre uses it a lot. It helps break the cycle. It's a nice way to get them moving. It's non-weight bearing, and it desensitizes them in some regard. So I think that if I have a patient like this, I'll often start with water therapy. I know it's hard to find. I know the patients, are like, I'm not getting in a pool. But nonetheless, I suggest it all the time. I mean, my fellows laugh at me because I'm always like, water therapy. Acupuncture, I think, is underused. I think it's a great, it stood the test of time, so we talk about that. We treat the neuropathic pain. And I think that we start with topical lidoderm sometimes can help if it's very local, and then we move on to more systemic type treatments. And then this is, again, the Strac thing here, exercise prescription. So I help them start an exercise program. I get them moving every day, even if it's just for 10 minutes, I think it helps. and it helps with sleep, it helps with pain. So use exercise as your medicine, and I tend to do that a lot. And then, of course, selective injections, which I talked about. I started her on Feldene. I did a topical lidoderm patch. We did a directed therapy. I sent her for good therapy with people that I know to focus on strengthening and stabilization and stretching. I gave her an exercise prescription, which I think helps. And I started her on water therapy. We considered acupuncture and Neurontin early on, and we talked about that. So I'm not, clearly I'm not a physical therapist, but I think it's important from our side, the medical side, to really reinforce the therapy. I think sometimes the patients, it really helps the patients, and it helps kind of build that bridge. And we encourage, I talk to them about it, I ask them what they're doing, I reinforce it, I encourage feedback from the therapist. So I think it's important to acknowledge what they're doing, figure out what they're doing, learn how to talk to them about it. I tell them to get on to perform better and get these back. I mean, if usually someone else has told them that, but I think that they're $3. They can do it at home. Nonetheless, I think it's important that they hear it from our side as well. So selective injections, we had a little bit for her in particular. There was a series of things that we could have. We could do, and again, go where the money is. So a very careful physical examination, and then start. And for her, she had some irritation of her iliopsoas, but we actually focus more on the lateral soft tissues. In the post-op patients, so we know that iliopsoas tendinitis is common, and there's some good data on this. Dr. Yan and Dr. Adib, they reported this in an abstract that it occurs in approximately 25% of all post-operative patients, so it's common in the post-op course. What about the lateral hip pain? I think that's common in the post-op course as well. And not all troch bursitis, and this is the point of this slide, is that not everything is troch bursitis. I think we see, again, a very young, active population. We see a lot of glute medius tendinitis, or tendinopathy, if you will. And there's been some good data to show that troch bursitis is associated with tendinopathy, so focus on that glute medius. And then this is an excellent article by Philippon in AJSM in 2011. He talks about that glute medius weakness, psoas tendinitis, or psoas injury, or psoas pain interplay. And I hate to be a muscle of the month person, but I think the glute medius is obviously very important. It's very, weakness and fatigue can cause an excessive pelvic rotation, and femoral internal rotation influences the function of the hip, the knee, and the back. It's often weak pre-surgery, and it's often worse post-surgery, and I think that speaks to the fact that these patients who are preparing to go into surgery, there's a huge role for us to reinforce the importance of strengthening pre-surgery so they get things strong before they go to surgery to help their outcome. So I think that's really important for us to reinforce. And pain management, of course, I talked a lot about this, but again, the use of non-steroidals and topical gel. And again, for the hip, I'm not exactly sure how effective it is, but the truth is some patients really like it and they feel like it helps, so go ahead. Extensive rehabilitation, and then we consider injections in the bursa just deep to the gluteus medius, and under ultrasound we can look at the glute medius tendinitis and see if there is tendinopathy. If there's extensive tendinopathy, we move forward with, we consider PRP and some other treatment modalities. And then, do you know how much time I have left?